So today we'll be discussing part two of the eosinophilic lung diseases. So I have nothing to disclose. We'll finish up today by discussing the EGBA and hypereosinophilic syndromes. We'll try to very much kind of recap what we discussed in the first and the second part today by establishing a bedside approach to a patient with eosinophilic lung diseases, and hopefully there will be some time at the end to um, do some case discussion about one of the cases that we saw on consult. So as you all know, EGBA is part of the ANCA-associated vasculitis of the small to medium, blood vessels. And this is from the, I think, 2013 or 2012, Chapel Health classification for vasculitis. Epidemiology for EGBA, it's again, it's one of the zebras, but it's rare, about 18 cases per million in the United States and about 14 in Europe. But the question is it really rare? And this is what actually some experts, they think about it, because we think it's more, at least it's still rare, but it's not as rare as what we think because of poor physician recognition. Because as what we will show you later, so all these patients, they have difficult to control asthma and they get labeled as that, and they are on steroids because of the asthma, and that suppresses the systemic manifestation of AGBA. So it actually makes it one of the most challenging diagnoses to make, actually. And in fact, also this disease occurs in phases, as what we will be discussing later, and that makes it kind of challenging sometimes to make a diagnosis. Usually it's more common in male than females, and it's the peak age is about 35 to 50. So EGBA association with certain medication. So leukotriene, receptor modifiers, high dose inhaled corticosteroid, and omalizumab was associated with EGBA disease, and it's because of unmasking more than a causality relationship. Because when you start these medications, someone with asthma, of course, so that will make you maybe go down in the dose of the systemic steroids, and that will actually unmask the EGBA.
You mean like with initiation of those medication, or with weaning off of those medication?
When you have someone with, of course, most of them, they have asthma, and when they get started on these medications like high dose, you optimize the inhaled corticosteroid, you start them on, leukotriene, modifiers, or maybe at the time, I think the only biologic that they had about, asthma is omalizumab. So that will result in decreasing the steroid burst and systemic steroids. So they found like the EGBA, cases, is rising, and this is because of the suppressing the disease activity that the patient had because of the steroids. Once you go down on the steroids, so the systemic manifestation of EGBA will come up. But there isn't any, good data to support that there is, cause and effect relationship between these and, the onset of EGBA, even though it's still controversial. Also, it's been reported with people who are smoking, free base, crack cocaine. It has been reported in few cases, and this is actually one of the case reports that I read about cocaine-induced Churg-Strauss vasculitis. And hold on this, because we'll come back and discuss it, because it has to do with the case that we're gonna be presenting at the end, hopefully. So this disease occurs in phases. The first phase is the allergic or atopic phase, where patients will have only like allergic rhinitis, some chronic rhinosinusitis, and asthma. And then that's followed by the eosinophilic phase, where there's lots of eosinophils in blood and also in peripheral tissues, and finally the vasculitic phase. So it has been reported that, especially like the asthma, the allergic phase, it kind of predates the vasculitic phase by about, on average, 8 to 12 years. So these people, they have asthma, and usually the asthma is not, bad up until few months, on average about, 6 to 12 months prior to the onset of the vasculitic phase, where the asthma becomes difficult to treat, in some papers. And there is no guarantee it can progress very fast over months as opposed to years, and it can happen in any direction. So you don't have to have this, classic, phasic pattern, because you can have simply the allergic and eosinophilic phase happening at the same time. But this is, the classic way. So the message from this is just for us to know that we have to intervene before the vasculitic phase happens. If you have someone with, hypereosinophilia and, some asthma and, maybe some other concerns that makes you think about EGBA, especially like the other non-vasculitic manifestation of EGBA. So you have to act quickly and treat them quickly to prevent the vasculitis from happening, because once the vasculitis happens, so patients will ensue, some degree of mortality and morbidity that's associated with it. So EGBA is, a disease that has a lot of, systemic manifestation. And as you see, so the table that you have on left is just the summary of the two actually cohort studies where they had almost about 100 patients in each one of them. And as you see, asthma is a disease-defining, feature. So you have to have asthma. Almost all of the patients, they should come to you first because of asthma before you discover the AGBA, followed by some kind of, polyneuropathy or, mononeuritis multiplex in about 3/4 of patients, sinus disease in about also 3/4 of patients. Diffuse alveolar hemorrhage is not common, and it's and these two cohorts, it's ranging between like 0 to 3%. So it's not like the other ANCA-associated vasculitis like GBA and MPA as well. The other systemic manifestations, they are there, but they're not as common as the first three ones. So for respiratory system, of course, you have asthma, you can have eosinophilic pneumonia, you can have pleural effusion, and lots of, CT scan, abnormality patterns that we will be discussing in the next slide. You can have constitutional symptoms. You can have, pancreatitis, cholecystitis, you can have ischemic bowel from, the ANCA-associated vasculitis. You can have cardiomyopathy, heart failure, arrhythmias, some kidney infarct, glomerulonephritis, even though like kidney involvement is not that common in EGBA. Neuropathy, you can have cerebral vasculitis, you can have poly and mononeuropathy as well. And the skin manifestation are really the key sometimes. If we find them in physical exam, they're very, very helpful. So you can see like the picture for the foot that shows the palpable purpura and some, skin ulcers with, erythroderma and some skin, nodules, especially like on the palms and actually soles as well. Usually when it comes to the labs, you can have usually like eosinophil count in the range from 5,000 to 9,000, but usually it's, above 1,500. If you do a bronch, the BL usually shows more than 25%, and also increased total IgE and the other inflammatory markers. So the question is, how about the ANCA, panel? So it's only positive in 30 to 60%. So that means it's a flip of a coin. So almost 50% of the time, on average, it will be negative. So if you shouldn't be relying on the ANCA positivity in order to make the diagnosis. Usually it's a P-ANCA and PO type of, profile, but you still can have C-ANCA and PR3, which is rare, but it can happen in, less than 2.5 of cases as well. So the diagnostic actually utility here is that it helps you to make the diagnosis. It's very supportive to make the diagnosis, but it's not, required. And it doesn't correlate with the disease activity. So in a retrospective analysis of nearly like 850 cases, when actually across multiple centers in Europe, when they looked into the ANCA positivity status, so about 70% it is ANCA negative, okay? And MPO, P-ANCA profile is positive in nearly 29 or 30% of patients, and PR3 and C-ANCA is about 2.2%. And when they looked into the, PR3, C-ANCA group of people and compare them to the ANCA negative and the MPO P-ANCA, positive, they found that the PR3 C-ANCA, they have, less eosinophilia, less asthma, so less A to B-like features, less neuropathy, and more skin and pulmonary nodules. So EGBA, you can have mainly, it's a different phenotypes. It's not just, one size, fits all. So you can have vasculitic phenotype, you can have eosinophilic phenotype, and you can have a mixed actually type. The vasculitic type where you will have more, palpable purpura, neuropathy, renal involvement, and biopsy-proven vasculitis, and of course, positive, ANCA, panel as well. And it's about 40% of patients. And the 60% of patients, they have eosinophilic tissue, phenotype, where, one of the actually most important complications is the heart involvement. So it happens more, with the tissue or eosinophilic tissue phenotype more than the vasculitic phenotype. And also the lung and the heart involvement, they seem to be more, happening with the eosinophilic tissue phenotype than the vasculitic phenotype. Pathology, usually these patients, as I said, so they present with multiple, system involvement. So your, first bet will be to biopsy the extrapulmonary organ, whether that's skin, peripheral nerve, whatever. Okay. So the priority will be to biopsy those, systems or those organs. But if you don't have any extra pulmonary manifestations, then you biopsy the lung. And it's still the surgical lung biopsy is more favored than the transbronchial biopsy, because with vasculitis, transbronchial biopsy, the diagnostic yield is not that great. What you see usually is three things, especially like if you are biopsying the lungs, and those are the three cardinal features that we look at in any lung biopsy if we're looking at EGBA. So the vasculitis of the small branches of the pulmonary artery, often necrotizing, and you will have granuloma and non-caseating granuloma, and you will have also some eosinophilic and giant histiocyte infiltrate. And what you see is just the representation of what I told you around the pulmonary artery branch. You'll see the bilobed, nucleus, which represents the eosinophilic infiltrate. And this is from a transbronchial biopsy, but it was be able to demonstrate some eosinophilic infiltrate. So chest imaging, chest or pulmonary infiltrate on chest imaging, it happens in about 70% of patients. So if you have someone with asthma and abnormal CT scan, so your differential diagnosis will not be asthma. So it will be asthma plus something else on top of asthma, because asthma itself it shouldn't explain the infiltrate on the chest imaging. If it happens that you see someone in your clinic and you order a CT scan on them and you see infiltrate, so that should make you think about EGBA as one of the differential diagnoses. So there is no specific pattern, but it can range from, ill-defined, opacities like GGO, some migratory opacities, and some interlobular septal thickening, some nodules, some bronchiectasis, and peribronchial thickening. So the airway is involved as well. And I think because if you see, and I'll show you some pictures and some data also, that I think this is because of the in the peribronchovascular bundle, there is a connective tissue and there is, blood vessels. So especially like with the vasculitic pattern and the, eosinophilic infiltrate, because that can affect that space. And on the CT scan, so you will see the peribronchial thickening and the airway involvement as well. Because it's not mainly just only parenchymal disease, it can affect your airway as well. So in actually a study of about 17 patients, I think this study is biopsy proven, EGBA, as what you see, bilateral, opacities with pleural effusion, very extensive, pneumonias. You can have, just only focal, airspace disease with, in some areas, it appears as if it's even crazy paving. You can see nodular infiltrate. You can see some central pulmonary nodules. You can have, thickened interlobular septa. You can have some bronchiectasis. You can have some, peribronchial thickening as well. and especially like what you see in this, where mainly like the airway, and there's lots of infiltrate around it. So the definition or the differential diagnosis of asthma plus infiltrate, you think about ABBA, you think about AGBA, hypereosinophilic syndromes, and idiopathic, chronic eosinophilic pneumonia, because especially with AGBA and ABBA and chronic eosinophilic pneumonia, these patients, they have asthma. With the exception of the chronic eosinophilic pneumonia, it's not a disease-defining feature, but it's present in about 70% of patients. And I put here the hypereosinophilic syndrome, not because that it is associated with asthma, but if you're thinking about asthma as a differential and someone presenting with eosinophilia and multiple system involvement, one of the things to keep in mind is the hypereosinophilic syndrome as well. And if you have a migratory infiltrate on the CT scan, it's just a reminder of what we discussed before. There's nothing specific, but it could be a long list of differential, more notable for ABBA, GBA, organizing pneumonia, chronic eosinophilic pneumonia, Loeffler, immune deficiency with multiple, recurrent pneumonias, and diffuse alveolar hemorrhage as well. And in this study, where actually they have almost 136 patients of AGBA, so what you see, there's nothing specific, but it's mainly, patchy consolidations with ground glass and also some airway involvement, a bronchial thickening that happened in about 1/3 of patients as well. So you can have also pleural effusion. You can have mediastinal adenopathy with AGBA as well. CT of the sinus is not required, but if you are thinking where to take the biopsy from, and the history is suggestive, but your bedside nasal exam is not helpful, you can get a CT just to see if there is any polyp or any significant abnormality that may guide you to get a biopsy. Oftentimes it can be helpful. And with the cardiac involvement, if you're thinking about you have AGB patient and you want to figure out whether or not there's a cardiac involvement, you start with the cardiac MRI, and all what it shows you is just delayed myocardial enhancement, which could be fibrosis or inflammation. So you follow that by PET scan, and if it's inflammation, it will actually light up. And the endobronchial or endomyocardial biopsy is one way also to go to confirm the diagnosis. AGBA, so when it comes to the diagnosis, all what you need to have is high clinical suspicion. I looked into the criteria, so it's different in multiple papers, and people, they have different, they keep proposing different criteria. I don't think that there is very good data actually to inform it, but here what I found is in one of the papers, one of the proposed actually diagnostic, this is a typing error, is a diagnostic criteria. So you start with asthma, as I said, plus eosinophilia anywhere. So I will be more concerned about AGBA if it's more than 1,000 to 1,500, plus two of the following. So either you have a biopsy, and the biopsy definitely shows you some eosinophilic infiltrate and some vasculitis changes on the biopsy, or you have ANCA positivity, you have palpable purpura, you have glomerulonephritis, neuropathy, diffuse alveolar hemorrhage, cardiomyopathy that is attributable to the EGBA, not cardiomyopathy because of ischemic heart disease or something else. Nasal abnormalities and pulmonary infiltrate on chest imaging. So this is for you to begin thinking about it. I think if you have ANCA positivity and you're lucky, and your ANCA is positive, along with what you have, it makes you feel comfortable about the diagnosis. But the problem comes when the ANCA is negative, and you, especially if what you have is just only sinopulmonary abnormalities. This is when I thought about it, or maybe abnormality on the CT scan alone. But if you have neuropathy, especially palpable purpura or glomerulonephritis, that's really clear on your urine analysis and renal studies. Those are what they call polyangiitis surrogate or equivalent. Because for you to have vasculitis, either you have a biopsy, or maybe even though like having positive ANCA, that doesn't mean that you have vasculitis, but it's very supportive, or you have systemic manifestation of vasculitis, like palpable purpura. If you see that, that's very, very helpful sign, actually. But if you have someone in your clinic or you see them in the hospital, usually they are sick and they have multi-system involvement, and you find some evidence of vasculitis either with lab or clinical, you can use this classification criteria. What you have the American, actually, rheumatology College of Rheumatology, and I think their European counterpart, where they have this classification criteria. It's confusing, but this is not for diagnosis, guys. This is for people if you have vasculitis and some pulmonary involvement, and you want to call it EGBA. But you have to ask yourself, is it EGBA or maybe some other form of ANCA-associated vasculitis? Because Wagner, the GBA and the MBA, they can affect the lung as well. So this classification criteria is meant to tell you your lung disease and the vasculitis that you have is mainly related to a GBA or GBA or MPA. But you should not use this for diagnostic purposes. This is only if you have EGBA picture plus some clinical vasculitis. So the actually diagnostic dilemma that we have is when you have someone with asthma, hypereosinophilia, and some systemic manifestation. When you don't have a biopsy and your ANCA is negative and you don't have any other surrogate of vasculitis, like no palpable skin purpura, there's no cardiomyopathy, that's attributable or could be attributed to a GBA. There's no alveolar hemorrhage. There's no neuropathy. At that time, it's very hard what to do with these patients. So we need to follow them closely because this disease happens in stages. So maybe now they don't have the EGBA, but later on they might have the other manifestation of EGBA, including the vasculitic manifestations. There is now a notion to call them hypereosinophilic asthma with systemic manifestation, but I have a question mark next to it, so it's not something that we'll agreed upon yet. And again, what you see in that box is that to tell you where this diagnostic dilemma comes from. This disease happens over time. They are already on steroids. If you are not the one who are giving them the steroid, they have received multiple exacerbations and steroids for asthma before coming to you, and they may not be positive for the ANCA. And of course, there are some other mimics that are very hard to differentiate from EGBA, like hypereosinophilic syndrome. When it comes to treatment, first you need to figure out how severe the disease is, okay? And whether or not there is organ-threatening involvement. So the disease severity is what they call like factor 5 score. So if you are elderly or if you have cardiac or renal involvement, GI involvement, so if you score 2 or more, so by definition, this is severe disease. And if you have alveolar hemorrhage, even if your factor 5 score is 0, it's considered to be organ-threatening involvement, also cerebral vasculitis and some cardiac involvement as well. So those are actually organ threatening involvement. The non-severe disease, usually like asthma with some pulmonary manifestation, but they don't meet what I just told you. So the treatment will be steroid, and people, they respond very well to steroid. Almost 90% of patients, they respond. But the problem is they have very high relapse rate. And some of the, studies when they were like, evaluating the rule for, mepolizumab, almost close to 5% of people, they will be able to come off the steroids. So there isn't that many people who will actually be taken off steroids. So this is the problem about it, but it's very steroid responsive disease. And especially with the non-severe, you can even start from the beginning with mepolizumab also, which is the anti-IL-5, therapy. So this is the randomized control trial that's published, I think, a few years ago, or about 5 years ago now, about the use of mepolizumab in patients with EGBA. So they recruited patients who are relapsing or having refractory disease despite being on steroids at least for 4 weeks or more, and they don't have organ-threatening damage. So again, mepolizumab is not for people with severe or organ-threatening failure. because their treatment is a little bit more aggressive, which I will tell you in the next slide. So they randomize them and they monitor them over, like a year, and mepolizumab was associated with 50% decrease annual relapse rate, which is really, remarkable. And also mepolizumab was, or the average steroid dose for the mepolizumab group when they added on top of steroids, so it was about 5 milligram per day, while in fact the placebo, they required 11 milligram per day. So it helps you to go down on the dose of the steroids, and it helps you to prevent relapse as well. Severe disease, of course, you need to start steroids, sometimes pulse dose steroid, and then you taper it off slowly afterwards. But cyclophosphamide and rituximab, they need to be used for treatment induction. So severe cases and organ threatening cases. So you need to be more aggressive from the get-go. And this is from the 2021 guidelines. So you need to start. The treatment I just told you is induction, but the maintenance. So these patients, they will need some kind of maintenance treatment as well. It's a little bit busy slide, and I'll leave it for you all so you can have it and review them later. So the bad thing about the GBA, it's responsive, but it will leave you with, kind of, chronic obstructive asthma 1/3 of the time. So 1/3 of asthma patients will wind up having chronic obstructive no matter how much steroid you give them. So it's a very significant part of the, AGBA-related disease morbidity as well. Hypereosinophilic syndromes is a big heterogeneous, group of diseases. So it's rare as well. So it's about 6 in every 100, patients. This is the prevalence rate. So in order to make a diagnosis, you need 3, and all of them, they need to be met. Number 1, hypereosinophilia, more than 1,500. As I said, in 2 exams, they're 1 month apart. And presence or evidence of end organ damage. So you should have multi-organ failure or multi-organ involvement, and absence of, the other secondary causes like drug or infection or other allergic disorders. So there are several actually, variants and subtypes of hypereosinophilic syndrome. So the first one is the myeloproliferative variant, and it's about 11. It happens in 11% of cases. So it's about some kind of chromosomal mutation, and they call it F1, P1, L1 BDGFR alpha fusion mutation, and a bunch of other mutations like JAK2 and G or F GFR1 mutation as well. So what they cause, so these mutations, they will cause some clonal proliferation. I think previously they used to call this variant chronic eosinophilic leukemia. So it's some defect in the bone marrow, and the bone marrow is just, producing lots of eosinophils and just, releasing them into the bloodstream. So when to suspect this variant is when you have, someone who is resistant to steroids, because hypereosinophilic syndrome, they still respond to steroid, but lack of response to steroid, elevated serum tryptase, B12, they have thrombocytopenia, anemia, splenomegaly, lymphadenopathy. They have some circulating blast or maybe some abnormal, bone marrow precursors on the peripheral blood film. They have elevated lymphocyte on the CBC. CBC, when you look at it, it's not just only about the presence of, eosinophilia, but if you see someone who has a lot of basophil, a lot of lymphocyte, so that tells you that there might, that makes you think about HES, the hypereosinophilic, more than the other, problems like EGBA. And of course, if you have bone marrow, that will give you some clues as well in terms of increase the cellularity and increase mast cell percentage, and also blasts as well. The other variant is still a bone marrow problem, which is a T cell variant. And the problem here is just only there is a defect in some, T lymphocyte, and that clone of T lymphocyte will be producing, a lot of IL-5. And if you remember from the first lecture, IL-5 is the most important thing for differentiation and, growth and maturation of eosinophils. And hence, you will have more circulating, peripheral eosinophils. And if you do flow cytometry, it will show abnormal CD3, CD4 cells. Things for you to be kind of cognizant when you evaluate these patients. If you have someone with lots of urticaria, skin blocks, that can make you, and especially when with a clinical picture that goes with HES, so that makes you think about, lymphocytic variant. And these two variants, it makes everyone nervous that we don't want to miss these two, because if you think about it, this is something that needs to be identified and, fully worked up by hematology to make sure that we're not missing any kind of malignancy. The idiopathic hypereosinophilic syndrome, they maybe in future they will change this, but as of now we don't know what's causing hypereosinophilia with end organ damage, right? And no other explanation for the eosinophilia. It's about 1/2 to 3/4 of patients of the hypereosinophilic diseases, they are idiopathic. We don't know what caused them. Sometimes you might see someone with, familial, HES. So they have autosomal dominant problem. It's since birth. But if you see them and they don't have any organ damage, and they have, peripheral eosinophilia for a long time, so this is something, that you may consider. And the last entity, which I say overlap or organ restricted, this is the most dynamic and changing, subtype, because as I said, EGBA at times when you don't have vasculitis and negative ANCA and stuff like that, it's very hard to say that, this is EGBA. You can't make a diagnosis. So sometimes they get lumped and they get classified also under the overlap component, because clinically you cannot, tell them apart, and you cannot differentiate very easily between these two entities. So skin and the lungs are the main systems that are involved. So if you see like pulmonary, about 1/4 of patients and almost 1/3 of patients, they have skin manifestations. And when it comes to the lung, they can have anything: patchy, infiltrate, nodules, lymphadenopathy, pleural effusion, anything. So the treatment for the hypereosinophilic syndromes is mainly steroids. So you start with the steroids. And usually about 50% of patients, they will respond. And if you think that you're dealing with myeloproliferative variant, is the one that I told you earlier, where there's a chromosomal, mutation, these people, they don't respond to steroids, and their treatment will be, imatinib, which is a tyrosine kinase inhibitor. We're not going to be treating all of this, because you'll be, consulting hematology and working with them to come up with a treatment plan. But if the patient has just only idiopathic or overlap or lymphoid variant, steroid sometimes might just be the only treatment that they need to be on. Also, mepolizumab was approved as well to treat the hypereosinophilic syndrome. And as you see here, it has a very remarkable, actually, results in terms of decreasing the controlling the disease and decreasing the risk of relapse. And they excluded the patients with myeloid variant. Anyone with chromosomal abnormalities or mutations, they did not include them in study, because steroid is not their first and initial treatment. So this is a busy slide, but it just summarizes what we discussed about these three entities. So the first column is chronic eosinophilic pneumonia. Sorry, it's not here clear because of, it doesn't project well, I think, here. And the second column is Scherk-Strauss, EGBA, and the third one is hypereosinophilic syndromes. When it comes to the onset, so all of them, they present, in indolent way, like weeks over months. CT scan finding, maybe the chronic eosinophilic pneumonia is a little bit more unique, where you see like, more peripheral located opacities, either affecting upper and lower lobes or the upper lobes only. But the hypereosinophilic syndrome and EGBA, there isn't anything specific, but mainly you will see like patchy opacities. Asthma is a disease-defining feature for EGBA, and it's present in about 60 to 70% of chronic eosinophilic pneumonia. But the hypereosinophilic pneumonia, it's not part of the diagnostic criteria at all. Sinus disease, you can have it with the eosinophilic pneumonia, chronic eosinophilic pneumonia, and EGBA. Smoking is not, a feature of any of these, three problems. Vasculitis, you can have it mainly in EGBA, but it's not a feature of the eosinophilic syndrome or chronic eosinophilic pneumonia. The positive ANCA, as you said, you have to be careful. It's not available in all cases, or positive in all cases, 30 to 60%. And here, the neurological involvement, so it's common in HES and EGBA, but you can see it in chronic eosinophilic pneumonia. But if you see it in chronic eosinophilic pneumonia, always you have to question your diagnosis, because multi-system involvement, it's very rare, and it can happen with chronic eosinophilic pneumonia. But usually, once you have some systemic manifestation, so it could be just HES that was misclassified as chronic eosinophilic pneumonia. And all of them, they respond to the steroid. They have great response, actually, except the myeloid variant and the HES, they have 50% response rate. And all of them, they don't need any additional treatment, especially like they need additional treatment to steroids, especially like in EGBA and HES. But chronic eosinophilic pneumonia, steroid will be more than enough. But the problem is sometimes they relapse, and we need to taper it off very slowly. Mepolizumab can be used in HES and EGBA, and IgE doesn't help you to tease them apart because it's high in all of them. And if you see, again, any elevated B12 serum tryptase, hepatosplenomegaly, whatever, or any abnormalities in your CBC far beyond the peripheral eosinophilia, then you think about the HES and the myeloid and the lymphoid variants. This is not truly like, hypereosinophilic, disease, the aspirin exacerbated respiratory illness, but I'm just putting that here because, ERD is, present in about 7% of asthmatics, and they have higher than usual peripheral eosinophil count when they compare them to the aspirin tolerant asthma and the healthy, control. But it's not, like in the 1,000 or the 1,500 range. Usually it's about, 450 higher than what your, asthma patient will have as far as, as far as eosinophil, absolute eosinophil cell count. But if you think that, okay, this patient has asthma and they have aspirin and maybe they have this entity, and you see like peripheral eosinophil count 1,500 and you want to attribute it to this disease, I would say you need to consider the other diagnoses first, because aspirin exacerbated respiratory disease, they don't have very high peripheral eosinophil count, more than 1,000 to 1,500. So quickly, I will just go through this approach. So history is the most important thing. And I think, try to make sure that you confirm your asthma, you get any history about any prior sinus problem, because if you refer to that table, because that helps you, because you will, at the end of the encounter, you will be like giving them, plus or minus, they have this, but they don't have this. So your history should be guided to, ask and assess about the presence or absence of any significant, nasal sinus disease. The asthma part, you review their medication, use pneumotox, remember the red flags, minocycline, nitrofurantoin, daptomycin, mesalamine, and the other medications as well. The travel history and where they reside in the United States, if they recently immigrated from another country, so that, will help you to guide your, infectious workup if you need to do any. Make sure you get a good history about, drug abuse and any exposure to animals, any occupation exposures is very important as well. And also get a very good and detailed review of systems, because I keep saying multi-organ involvement, you're not going to pick that up if you don't do the review of systems. So the template that we have, which we only ask about one question, if we do, I don't ask any question, but sometimes I do. With these patients, don't memorize, print it out or put it in front of you on the computer. Every single symptom matters, because they're not going to volunteer this abdominal pain, and this abdominal pain could be pancreatitis, and they have vasculitis, right? So you have to be detailed. There is no excuse. There is no way. If you want to pick up the multi-organ involvement, you have to get extensive review of systems. Physical exam, not very helpful, but mainly skin, hepatosplenomegaly, lymphadenopathy, and if you do nasal exam, and you see any abnormality. The workup, so there's workup for everybody, and there's workup that's guided. It should be guided by your history. So, like, you can send, evaluate first. If you see peripheral eosinophilia, go back in time, get prior records, because if they have peripheral eosinophilia 20 years ago and they are still living and they don't have any organ damage, okay, so this could be just familial or something else. So you have to look at the prior records. B12 serum tryptase only if you have any concerns about, as I said, some anemia, thrombocytopenia, something to make you think about hematological problems. If you have someone with asthma with hypereosinophilia, I would go ahead and send a BBA workup. You send total IgE and panel, very appropriate for everybody. It doesn't hurt to get abdominal imaging. Make sure that you're not missing, hepatosplenomegaly, LFT, RFT, UDS, because we believe our patients, but it's good to confirm because sometimes what they take is what's causing, the lung disease and the peripheral eosinophilia. CT chest, because I wouldn't advocate for X-ray. You can get it; it's very good, but if it's negative, you still need to get X-ray because you may not see the very subtle findings, especially like with APPA and the multi-system and the nodular involvement and AGBA as well. Autoimmune workup, I would say only if you have concerns about, especially like Sjogren and rheumatoid arthritis associated with some eosinophilia, not about the rest. The fungal workup only if there is a travel history, with the exception of strongyloides. You have to get for everybody, HIV, of course. And you refer to hematology if you have the features that I just told you about the myeloid variant. But you have always to keep in mind that don't assume that this is not, especially when there's a lot of features to make you think that there's a bone marrow problem, you need to send them quickly. It's a multi-organ, or a multidisciplinary, teamwork. So it's not just only pulmonologist. You need GI, cardiology, allergy specialist, rheumatology. So you need to work with the rest of the other people in order to, treat these patients. So I'll get to the case. 58, active smoker, male, active smoker, white male, active smoker, with history of possible asthma versus asthma COPD overlap. He has a history of allergic rhinitis, heart failure with preserved ejection fraction, who was admitted with 5 days of worsening dyspnea, cough, wheezing, and new hypoxia. The pulmonary service was consulted because of frequent COPD exacerbations in the last several months and abnormal chest CT scan. Apparently, the patient was given a diagnosis of 2000. I'll just take it in sequence in time. I'll just try to be more chronological here. So in May of 2000 and 2022, the patient was admitted to St. Mary's, and he was treated as asthma flare-up, and he had a BFT done while the patient was admitted, and it showed mixed obstructive and restrictive pattern. And he had some peripheral eosinophilia. I think his eosinophil count was about 750 at that time, and he has a positive C-ANCA and PR3 titers as well. The patient was seen by multiple providers, and he was asked to come to follow up, I think, with HIMG pulmonary clinic, which he never did. So his breathing problems started, when I talk more history from him, started in his mid-20s, and he was only using albuterol as needed. And his breathing symptoms was fine up until a year and a half ago when he started to have more breathing problems. He cited common cold, hot, humid weather, some extreme cold to be the main triggers for his cough and wheezing. He has history of allergic rhinitis that's bad mainly in spring and fall. Denied any recurrent sinusitis or any prior nasal surgery. In August 2022, he was admitted to St. Mary's with worsening dyspnea and was treated as a heart failure. There's no imaging there, but he was found also to have MSSA septic arthritis that was treated with cefazolin from August to almost the end of September, and then they switched him to the smoking gun, daptomycin, October 13 to November 2023.
Just to interrupt you a little bit, Tarek. So in this admission, his periphery eosinophilia is still persistently high, or
I'll show you in one of the other slides. I can't. I think in August, no, it wasn't. But when he first was admitted in September and May, it was high, but not terrible, 700 something.
Yeah, in May was
High,
but
high.
when he came back,
When he
on
came in August,
it was not
no, it wasn't. I don't think I will have it in the, and I
Okay.
created a table that has all
Yeah,
the
yeah.
labs, but I don't think so. And they treated him as heart failure. They gave him some diuretics, and they found that he has septic arthritis stemming, I think, from his chronic gout. They aspirated his knee and they diagnosed him with MSSA, septic arthritis. They gave him these 2 antibiotics. But just hold on the daptomycin, we'll come back to it. So in December, December 21, 2022. So I mean, past
Yeah.
December. So he was admitted with another illness, shortness of breath, cough, wheezing, blah, blah, blah. Admitted to Kabul, treated with COPD and pneumonia. We weren't consulted back on him. And he had abnormal infiltrate also on his CT scan. And also when he had peripheral eosinophilia in December as well. And then last admission where I saw him, he was admitted on, January 9th of this year. And he came with 5 days history of dyspnea, wheezing, and productive cough, and some new hypoxia. And if note, in between attacks, the patient, maintains, adequate saturation just only on room air. He denied this time any history of fever, chills, sick contact, chest pain, hemoptysis, or any palpitation. He has leg swelling that he attributes to chronic lymphedema that's been there for several years. As far as inhaler treatment, prior to coming this time, he wasn't on any inhaler other than, some PRN albuterol, and he stated that he couldn't afford the LABA/LAMA ICS that his, PCP prescribed him to. Literally, he was on nothing other than some PRN, albuterol.
So, and for the infiltrate, the first time he had pulmonary infiltrate, or we had imaging, was the December admission, is that right?
So there, I'll show you. There's an infiltrate from May 22,
Since December.
and there is December 22, and there's
So the one
January.
in between the August, he did not have any imaging.
There is no imaging.
Okay.
I have all the imaging, the CTs that he had. Where were we? We were here, right? Okay.
Next.
All right. So only received the steroid burst during the previous admissions and denied being on a long-term steroids. By the time I saw him on that admission, he was already, getting some course of prednisone as well. And the patient was very upset and angry, difficult historian at times, and very moody. And he was very concerned that he's getting worse and no one is paying attention to him. And he didn't know what was happening and why his health was going downhill in the last a year and a half. His past medical history, he has gout, CKD stage 2, GERD, obesity, and allergic rhinitis. Surgery, nothing really exciting other than removal of a tophaceous gout from his, I think, right elbow. Medication, he's on allopurinol for 20 years now. PPI, metoprolol, losartan, and he's taken ibuprofen, PRN as well. And he's on Lasix and aldactone for, HFpEF. Nothing significant on his family history, his social history. No recent travel. He lives in Huntington. No exposures to animals. No significant occupation exposures. However, he spotted a lot of mold in his, apartment or his house. He said it's due to a water leak, and it's been going there, and it's been going on for several months now. He actually admitted that he infrequently smokes, crack cocaine, marijuana. Sometimes he sniffs cocaine as well. He added that when I saw him in clinic. He drinks alcohol somewhat heavily. He's active smoker, not very heavy, but 1 to 2 packs per day, and started in early adulthood. And he's still smoking up until we saw him in the hospital, so he did not quit, but he's not heavy smoker. So review of system, nothing really exciting. So he had, no significant nasal symptoms or epistaxis at the time we saw him. And his musculoskeletal exam, he has some arthritis, which he attributes to his gout. But there is no significant, Raynaud phenomenon, or maybe some other, mouth or orogenital ulcers as well. And there's no skin changes other than the chronic tophaceous lesions that's noted on his skin exam. And there is no history of neuropathy or muscle weakness. Physical exam, nothing really going on other than him being on oxygen, and he has some bronchi. He has no clubbing, no significant skin lesions other than what I described to you, but there's no petechiae or purpura. And those are his labs. So if you see for the absolute eosinophilic count, it was high when he was admitted and treated for COPD flare-up, and slowly vanished, I think, with steroids. And then to answer your question, I think in August he didn't have anything, I think maybe 150. And it started to come back and in 2016 and 17, it was normal. Okay, there's some old labs in St. Mary's that I was able to look at. Also in October, if you see, it's almost 1,400, and that was even before the daptomycin was given. And the cefazolin, I looked it up, it's not associated with, you know, any significant eosinophilia, maybe in like anaphylaxis or some other stuff, but it's not like eosinophilic lung disease. And it also continued to be the case in December when he was admitted. He came with almost 1,000, and that went away next day. Same thing this time. He came with 1,400, and next day they gave him whatever steroid that day, and just, you know, all his eosinophils actually melted away. And there is no increase in the number of eosinophil basophils or anything to make me think about hematological disease. The other labs, his total IgE is high, about 1,600. And his C ANCA is positive. The pattern is C ANCA, and the titer is 1 to 640, and his PR titers are high. So it was confirmed this time, and also they were high last year in May. But I think no one did anything for it at the time. The patient was discharged, asked to come to follow up, but he didn't do. His MPO titers, they were normal. Serum tryptase, you know, B12, everything is normal. Autoimmune workup, comprehensive negative. Strongyloides positive, the serology, but he doesn't have symptoms. His UDS multiple times in January and also in October of 2022, it was positive for cocaine. His immune deficiency workup is negative. Anti-Aspergillus specific IgE is slightly positive, not very high, but it's slightly positive. The IgG, the Aspergillus specific IgG, is negative. And his inflammatory markers are within normal limits, and he doesn't have anything on macro, everything is negative. And his UA is bland, there is no cast or RBCs or any proteinuria, and his liver and kidney functions are normal. So this is the CT scan. If you see, so the first row on top is, you know, taken maybe at the level of, you know, upper lobes, and the one down is in the lower lobes. And if you see in May, so he has some infiltrate in his right upper lobe, maybe a little bit in the left lower lobe, and there's some hazy also ground glass, you know, predominantly I think in the, you know, right middle and also right lower as well. In December, so it's the same presentation, by the way, oxygen, treated as COPD exacerbation, few days of respiratory symptoms, and what have you. So in December, if you see there is some ground glass opacity in the left upper lobe, right? And most of the changes that we saw back in December or in May, they went away. And few weeks after that, he was admitted in January. And if you see the infiltrate that he had in December in the left upper lobe resolved, but he has now some kind of, you know, infiltrate with some tree and bud changes also that's noted in his right upper lobe. And down also he has something in his right lower lobe as well that wasn't present, you know, a few weeks after that. So that will make you think about what, guys? This is what I thought about. He had some infiltrates, they were coming and going. But that, what do you think?
If I would like to be
Mm-hmm.
simple and a street pulmonologist.
Mhm.
So he has C ANCA positive, and that can be explained by his cocaine inhalation and sniffing, and that's it has a high chance of being positive. And even if sometimes you do biopsy, you cannot differentiate between cocaine induced vasculitis or GPA vasculitis. So therefore,
If they have destructive midline destructive
that's
disease, right?
Yes, that's right. So, which he had a positive UDS for cocaine. So that's like I can blame that on cocaine, which is more common than the 2% of the EGBA. So that's like how I will think about it. And looking at the positive eosinophils, history of asthma, eosinophils more than 500.
We're confirming the asthma, by the way.
Yeah.
He was giving that label, but someone started
Yeah, I mean,
having
asthma, yeah.
history suggestive, but
Yeah,
I'm not 100%.
Say asthma, yeah. Asthma, like I have two of the measure criteria, like IgE more than 1,000, eosinophils more than like 500.
Yes.
And like I can say like this patient had an ABBA at the beat, like as a first picture with like a little bit of raised IgE to aspergillus with his leak and his house. So I will go toward like ABBA more than anything else.
Anything else?
Yeah.
With the cocaine being in mind, being maybe one of the drivers for
right.
this.
So that's why me personally, I would treat as an ABBA first and see what will happen because I don't have like other feature systemic involvement.
Correct.
Yeah,
For
and then I will
AGBA.
go for, like if things are improving, patient like eosinophils is going down more than 35%, symptoms more controlled, everything is good. I will just stick in that route. If not, then I'll say, okay, this is most probably I need to do more workup
for something else.
GPA or like
But this is your explanation for this abnormal, maybe the labs, especially like the vasculitic panel that he has.
That's right. Yeah.
Because it's true, because we confirmed that maybe if it's only Cianca and it's not pairing with PR3, then that the diagnostic value goes down, but we confirmed twice. Samir is in May now, both of them they're high and they're going side by side. Anything to add?
No,
Before
I mean,
we
the
see that.
treatment would be the same, because even if he has EBPA, it will be non-severe because he does not have organ involvement. It looks like it's just pulmonary involvement. So
Right.
the treatment for that would be steroids.
And you'll be in stage
And-
3.
and this is what I did.
He had the first episode, and then he had remission, and then he had again exacerbation, and then now remission. So he's not steroid dependent.
Correct.
He's not.
And I will
fibrotic.
admit, this is not what because when we see someone with ABPA, they're already on treatment. And what confounds the whole picture, this guy literally, okay, was on no treatment at all.
Yeah.
Even if he has asthma, what was he taking? It's not like difficult,
No,
but he's not
because-
even on
yeah.
treatment to begin
Yeah,
with.
yeah.
Okay. So this is his PFT. And unfortunately, I don't know why they didn't do the reversibility and there's obstruction. But anyway, it wasn't done. And there is, about, severe degree of obstruction and some restriction as
This is
well.
during the admission, though, right?
They did it as Mary's the third
In
day
May.
of him being admitted.
Being admitted. So this
Last
during
year.
the flare-up.
Acute.
During the flare-up. Yeah, that's during the flare-up. And I don't know, he will have albuterol toxicity if you give him a dose and do it. Anyway, so we had everyone to see him except rheumatology. So we invited him, but it didn't happen. So ENT, they scoped him, they looked, they said there's nothing, okay, in his nose, polyps, anything. His CT sinus, some chronic ethmoidal changes, but nothing in his, maxillary sinuses. Nephrology, we consulted them. They said this is, and I agree, there's nothing. We got all the workup, mainly CKD stage 2 from chronic gout. And as I said, ENT was consulted. And what I ended up doing for this guy, I don't think that he meets the whole criteria for ABBA, Muhammad, but I treated him as such, and I was planning to treat him. I lost him, by the way. He didn't come to follow up as usual. I saw him, and they saw, I will see you in next.
This all workup and like.
Unfortunately,
failed.
and he's not even answering the
His
phone.
history and lab.
So I thought about ABBA, but I think if you look at the criteria, he doesn't meet it all. But I think he has asthma. Let's assume that he truly has asthma, even though we're still confirming that, but most likely he has it.
And IG more than 1,000.
And IG more than 1,000, so he met that one.
IgE specific
And-
for aspergillosis spots.
And the IG, so he met the two obligatory.
Yes.
And because it's 3. Number
And
one,
he has one of the
define.
minor.
Correct. And he has one of the minor. And so the issue is that with the CT, so they with that criteria, so they will require him to have, at least 2, but he doesn't have the IgG. But I said maybe the changes that we saw, because they Sometimes they are here, sometimes they are there. So it could be, it's not like the very classic,
Yeah,
you know,
yeah.
central or
Mhm.
high attenuation mucus plus the what else that he had plus the eosinophilia. So this is what I thought. Maybe I will just give him, if we will assume that the CT finding is most likely something that can go. It's not very specific, but can go. I will treat him as such. And I was planning to just, you know, do it just only for 2 months. By the time I saw him once after discharge, and he said he feels great,
After you treat.
but I wanted him to see, because that was an early, he didn't show up for his last clinic visit this month. And I saw him on February 7th. So by February 7th, he said, "You fixed me. I feel good." He's on
I'll
steroid.
come back to cocaine.
He's on 35, okay, every day. So he took it for 2 weeks, and I told him we will switch it to every other day. And I need to see, because I'm planning to wean off steroid quickly, because this is not difficult to control, because he wasn't on treatment to begin
I
with.
agree with you.
I will not do it like the classic
Because there was
ABBA
a lot of
way.
maximum asthma
And-
treatment, and then it came back.
And by the way, we held his, once we knew the strongyloides, so we held his already steroid that was given. And one day Hamza, I think he gave him some of the treatment.
So
We give him ivermectin. So the treatment is give it for 2 days, and then in 2 weeks you
2
give him
weeks,
another
yeah,
round,
another
especially if
2
you're
rounds.
worried about immunocompromised patient. But no immunocompromised status, you give it 1 time or twice. I think 2 doses, right?
That's the one who fixed
2 doses, right?
One
Yeah.
dose, then one dose.
Yeah.
1 dose, but it's
Yeah,
one
yeah,
dose
yeah.
today,
It's
1 dose tomorrow.
2 weeks
Yeah.
apart, but
2 weeks apart.
So can we consider this is just because, I don't know, every time he come with this CT finding, is that cocaine was positive every time? Is that
he
explain
always
the
positive for
image
cocaine,
and then
Doesn't look like cracked lung or.
and he has a sino.
So one question, what do you expect with the cracked lung?
Like a little bit of ground glass opacity in the left upper lobe, it could be,
Mhm.
but usually it's bilateral and like ground glass opacity. It's not like very bronchiovascular.
And he's
What is the main lung disease that we worry about? It's,
Why
you know,
now?
diffuse hemorrhage, eosinophilic pneumonias, they can happen with
No.
cracked lung, but
I
that
mean,
doesn't
he
go with
used
it.
the cocaine for a long time, but he becomes sick since May, you know, start more.
So this is why AGBA is
Yeah.
on the differential, but not high. We will go with the
real
ABBA
practice,
and
do
the
you
others.
bronch him or no?
So.
Like, forget about
Like,
that.
question.
Yeah.
Question.
You got,
No, it's not like.
it's gonna help. It's gonna help you or no?
I think just to see his
When
opinion.
when he came in at the beginning,
Mhm.
the high eosinophilia and history of
If the steroid wasn't given,
yeah,
Yeah.
history of like
Yes.
asthma, and the steroid was not given in that time, I might just